Dear friends, colleagues, it's a great pleasure to welcome you to this new podcast of EHAT. Today, we will focus on von Willebrand disease and its diagnosis, and it's a great pleasure to welcome today Professor Flora Peyvandi. Flora, very happy to welcome you today.
Thank you. That's great.
Thank you, Flora. Well, I think that there is a little need to present you, but for people who do not know you, but there are, I think, very few people, you are a leading figure in our field. You are also, you are based in Milan, Italy, with a major experience in bleeding disease, von Willebrand, hemophilia. You're also the current president of ISTH. And recently, you contribute actively to an educational activity of EHAT focused on von Willebrand. And what we would like to do today is to give a flavor to our colleagues about the new guidelines. So maybe, Flora, you could tell us a little bit about the recent new guidelines on von Willebrand disease. What was the rationale and the reason for producing these guidelines?
Thank you, Cedric, and thanks to EHAT for organizing this moment, these minutes for focusing on why the guideline has been organized. Actually, I remember that for the guideline, we started with the World Federation of Hemophilia at the beginning, that there was a need for the preparation of the guideline for two reasons. One, because we thought it would be good to come up with some kind of a standardization of the response and understanding what are the science and the scientific messages that were supporting the positions in terms of the recommendation. And usually the guidelines are proposed when there is new assays coming to the market or there is new component for the treatment coming to the market. So we had few assays that were proposed recently, and also the recombinant von Willebrand factor and also the pure plasma-derived product was added to the rest of the product, which was containing factor VIII and von Willebrand. So then we thought it's a time to come up with some kind of recommendation. The grading system has been proposed, and as you know, there is a list of the questions. And the clinician, the scientists, the lab people, regulatory people, they're sitting in the room and deciding what are the most important questions. And then there was a collaboration between the ASH, American Society of Hematology, ISTH, NHF, and World Federation of Hemophilia. So these four component and organization together with the lead of the ASH decided to organize the preparation of a recommendation in terms of the best diagnosis and the treatment of the patient with the available instrument that we had in place.
Thank you. So this is a very important and very huge initiative. What is, in your view, the target audience for these new guidelines?
I would say everyone who could have a possibility to meet a person with bleeding symptoms, with or without experience in terms of previous experience with von Willebrand disorders. Because mainly the first recommendation was on how I'm going in the general population when I see a person with some kind of mucocutaneous type of bleeding, what I should do. Should I use the bleeding score or I don't have to? That as an instrument should be used in what group of the people. So I would say every physician or lab person who was seeing a patient with bleeding manifestation, mainly mucocutaneous type of the bleeding.
Another question is about, there are several guidelines currently available. So what is, in your view, the major originality of this set of guidelines?
I think there were 2 or 3 instruments important to understand. First of all, in the assays, we were used to have in our lab the RICOF assay, which still is remaining one of the most available assay, and I would say a good assay. But there are also novel assays like GP1B assays, which is showing the binding of von Willebrand factor to the platelet, which mainly is important in understanding the subtypes of type 2 and, this dysfunctional von Willebrand factor, which was, I think, in this guideline very much noted. And secondly, also the differentiation when you're using the products which is containing factor VIII and von Willebrand factor, or the product which is only von Willebrand factor. And bringing, I have to say, for that point of view, I think we need also the further description on how to use, when you're using a pure von Willebrand factor, what you have to do and what type of assay to use. Because we were used to measure, for example, factor VIII for the management of the surgery or acute bleeding when we were using the component containing von Willebrand factor. But this recommendation is very much bringing also the importance of the RECOV, which should be described a little bit more for the people who are not familiar.
Coming back to, how can we find these guidelines? So if I'm correct, they were published in Blood Advance and they are freely accessible. Is that correct?
That's correct. And that could be used. And I think also I saw, for example, at the Italian level, and I'm pretty sure in several regions of the world, they made a kind of recommendation based on the availability of the regional lab assays and also the products on how to use this kind of recommendation. I think it would be also good to understand how many initiative has been done also at the European level to understand the interpretation of the guide.
Well, I will ask you a few questions about, the diagnosis of each type of Willebrand disease. But first of all, maybe we could discuss shortly how the bleeding assessment tool should be used and what is its importance in the diagnosis of von Willebrand disease. I think this is a very important section of these guidelines. So maybe you could tell us a few words about the importance of this bleeding assessment tool in the diagnosis of von Willebrand.
Reading the recommendation, it needs an art and it's difficult to understand exactly. But I will try to make it as simple as possible. But or the screening is useful generally when you are using it at the general population, as I said before, who have the mucocutaneous bleeding, because the sensitivity and specificity of that kind of instrument could pick up those patients that might have some abnormality in von Willebrand factor. And that means in those patients that there is a low probability of having von Willebrand factor, that becoming an important instrument to be used. However, if you have the member of the family or where you have more certainty that the patient could have the von Willebrand, that is not the best instrument. You should go with the proper testing of the laboratory testing and make a proper diagnosis. To make a long story short, I think this is what the people should keep in mind.
Thank you. And then, let's now move. So we have to use this bleed assessment tool, but clearly lab tests are important. And in terms of assay or functional assay, you already told us that there are no new assays that we should be used because the ristocetin cofactor probably belongs to the past. We now have to move to new assays to evaluate the functional activity of this von Willebrand factor.
Correct. I mean, even there, I know that there was a podcast for the proper assays, and don't want to go through too much detail. So, but we know that von Willebrand disease could be with partial deficiency, like type 1, or the total deficiency, like type 3, and dysfunctional von Willebrand factor, which is the most difficult type of the diagnosis. And there are 4 types, A, B, M, and N. Mainly, the assays that we have to keep in mind is how much protein is secreted. So antigen of von Willebrand factor, the activity, as we said, is measured with RECOV, and still RECOV is used, but the recommendation is using the GP1B binding assay and trying to understand what is the level of the binding of the platelet to von Willebrand factor. Why that is important? Because in type 2, most of the types that you can see that there is an alteration between the platelet and von Willebrand factor. How we are going to make the distinction? So there are also additional type of the assays, which is important, is actually the multimer analysis, which is, we know, is difficult, not available every places. And that's the reason why in some centers the collagen binding assay is used, but using the collagen type 1 and type 3. Now, Genetic analysis is a very other important assay that is going actually to somehow substitute some of the multimer analysis in the future and some of the collagen binding assays. So what we have to do, first of all, make sure wherever place in the world we are, we have the antigen and activity. These are the first of von Willebrand factor and factor VIII. And making the proportion of amount of the protein and its activity is allowing us to understand whether there is reduction of both protein and its functional activity. That means it's type 1. And if there is no activity and no antigen, that's type 3. And if there is actually some of the protein present, but this is dysfunctional protein, as I said, is becoming more complicated because, for example, in type 2A, you can see that there is a depletion of multimers and there is a problem actually of the first primary hemostasis alteration. And this patient could be very severe and having severe type of mucocutaneous and GI bleeding, and that's the reason it's important. If it's type 2B, the binding of the platelet is much more compared to the normal population to multimers, and that event could be very, very various in different patients. In some patients, you can see the depletion of the multimers. In some you can see the high molecular weight. And actually, type 2N is a type that the alteration is due to the binding of factor VIII and von Willebrand factor. And that's the reason sometimes with a mild hemophilia could be a kind of misdiagnosis, and we have to be careful about that. And also in type 2M, we can see that there is an alteration in the binding of platelet with von Willebrand factor. Now, what is a difference of this guideline compared to the previous is mainly type 1. If you have a patient with less than 30% of activity, you can call it type 1 without considering what is the type of the bleeding. But if you have a patient between 30 to 50%, which is always the gray area, you need to understand whether the patient is bleeding or is not bleeding, and then going to the further type of the characterization. And on top of that, for type 2, the levels of proportion between the activity and antigen is not anymore considered to be less than 0.5, because we need a little bit more sensitive line, and that's considered to be 0.7. And that's the additional, I would say, point of this recommendation. And again, for further characterization, I think you can hear the podcast of Luciano and Omid for going to the detail of how I'm going to make the diagnosis in this patient.
And Flora, if I'm correct, the guidelines also emphasize the importance of considering taking into account the influence of age and comorbidities, because they can also influence a lot the levels, the values that we measure. Is that correct?
That's absolutely correct, Cedric. As you know, for years and years, we were having this consideration that sometimes we make the evaluation and the levels are between 30, 50 at the beginning, and we are calling this patient type 1. And then in the elderly age, the level of von Willebrand factor is increased, and we are a little bit confused whether we still have to call them von Willebrand factor type 1 or these are normal. And I think, first of all, the recommendation is the level of von Willebrand, as you mentioned, with age is increasing. The level should be measured more than once, twice or 3 times in a normal condition, understanding what is happening, even I would say every 10 years, to understand how this level is changing. And sometimes you might even want to consider to redefine the diagnosis. So you are perfectly right that the age is increasing the level of expression of von Willebrand factor, and the clinician should consider that.
And I have another question, because I know that in Milan you spent a lot of time, energy trying to better characterize type 2M versus type 2A. So to help us, our colleague, to better see, how these two diseases could differ, 2M and 2A, what would be your message?
Thanks, Cedric, for asking the difference between 2A and 2M. And as I said before, the details on diagnosis of von Willebrand factor, the subtypes, of type 2 has been described very well with Omid Seidzadeh and Luciano Baranciani from my center in the specific podcast on diagnosis of von Willebrand factor and von Willebrand disease. And to make a long story short, for 2A, you have to use different type of assays. Rykov collagen binding assay and the amount of the protein by antigen assay. So in type 2A, you can see that the ratio between the activity measured by both Rykov assay or CBA on antigen are low, less than 0.7. However, in type 2M, the ratio between Rykov on antigen remains low, but the collagen binding assay on antigen remains normal. And if you use the multimer analysis, you will see the loss of largest von Willebrand multimer in type 2A, and that is not something that you can see in 2M, where multimers result to be normal. You can, of course, use also the molecular analysis for the confirmation of these results, and that depends on where you are, in which part of the world, low resource country or high resource country, and how is the facility of the assays in your country. But this is mainly the assays that you need for the differentiation between 2A and 2M.
Well, thank you, and thank you for making all this so simple for our colleagues. So if you had we are getting closer to the end here, but would you have a final remark or suggestion based on our discussion and all the work you have done and the preparation of this podcast for our colleagues?
Actually, Cedric, I always thought von Willebrand factor is a complex molecule, multi-domain, and every domain is doing different. And for those young physicians who are starting, it's very complicated to understand. I think our society and EHAD should make as simple as possible, as we tried this morning to do together, to understand the role of this complex molecule in both primary and secondary hemostasis. And using the cartoons, using the new models, and trying to make the teaching easy for the patients, because this is really compromising the life, especially of the women. And we have to consider mucocutaneous bleeding, big bleeding every month, and also anemia and reduced quality of life. So we do need to make a good diagnosis and understanding it.
I think you are completely right. I think trying to make it simple, it's certainly what we are trying to do. So I'd like to thank you for achieving this. I think you really help us to make von Willebrand disease and its diagnosis much more simple. And I'd like to thank you for contributing to this. I'd like to thank all our colleagues and friends for listening to us today. And I invite all of them and all of you to go back to the EHAD website and platform, because there are plenty of opportunity to watch the great slides that have been prepared and the different talks addressing von Willebrand disease and its complexity. Make it quite simple. So thank you, Flora. I wish you a great day and hope to see you soon. And for all of you, hope to see you soon again on our platform and for our next podcast program. Bye-bye.
Thank you, Cedric. Thank you, EHAD. Bye.